All right, Mr. Chair, we're recording and live streaming. I will note that you do have quorum. We are just waiting for Naomi Vodden and Clark McFarland to join. I do see Dr. Era has now joined.
Okay, thanks, Madam Clerk. It's April 19th, 2022. It's 9:30 a.m. It's the Mental Health and Addictions Task Force. I'll call the meeting to order, and I would ask for any declaration of interest. Seeing none, if one arises during the meeting, you can declare at that time. Item number 3, presentation from Executive Director of the United Way, Bruce Gray, Francesca Dobbin. Francesca, good morning. You have the floor.
Good morning. First up, that's not at all scary. So do I have the ability to share screen? I do.
Yes, you do.
Let's put these 2 years of Zoom skills together. So thank you very much for the invitation and the opportunity to speak to you today. I've also been asked to highlight 2 other organizations in regards to their services, the Salvation Army Community Services, specific to Owen Sound, but I've included that they have locations in Hanover, Owen Sound, Port Elgin, and Wyerton as well. They are independent, autonomous organizations, so some of the services are unique to each location. They vary to each location. And they do have an application process with documentation around income status to require to maximize all the support. So there is a means testing, as we refer to it, to access supports with those organizations. It tends to be a very compassionate, where are you at, opportunity to engage with folks. The typical services provided by the regional Salvation Armies are food banks, which you can access once a month. You get 3 to 5 days worth of food. Many at this time of year are supporting or running income tax clinics, single day events, ongoing events. They do Christmas assistance, so that would be food hampers as well as toys, working in partnership with many community fire departments around Toys for Kids. They also provide emergency relief, food, clothing, household furnishings, all depending on if there's a thrift store available, what's been donated. They've been known to assist with hygiene items as well as incontinence supplies. And then additional services could be assistance with budgeting, filling out forms, referral to other community agencies as they're needed. Those are the typical ones. If you drill down locally into each community, they can be much more nuanced than the high level that I've given here. And Alice has signed off on these slides. The other organization I was asked to speak to was OSHARE. OSHARE's here in Owen Sound. They offer meals to anyone who requests one. There's no means testing to it. It's just show up, ask for a meal, you get a meal. During the pandemic, they've been providing takeout lunch and supper on weekdays and a bagged lunch on Saturdays. The whole goal, I think they were only open for maybe a week or 2 when the pandemic hit, is for their seating capacity is about 150 people at a time, which they would rotate over. So people would come in, have a meal, sit, and then leave, and somebody else would sit in that seat. So they're not limited to serving 150 because it will rotate with a sit down meal. And I know when they were across the street from the United Way here in Owen Sound, and I was over a few times to visit, if there isn't an empty seat, somebody always jumps up and says, oh, no, it's okay, I'm leaving, take my seat. So there's always that rotation piece. Above and beyond what they do, they've supported during the pandemic our Meals to Motels program. So people who were sheltered in motels from May 2020 through to September 2021 were provided a meal once a day. Meals were provided to them at the Travelers, at the Key and Chatsworth, and then various locations. During the Delta outbreak of June and July of last year, where we had people isolating in their homes or isolating in motels, they provided, we took boxes and did porch drops of 3 meals a day. Generally, it's a hot meal for whatever, like if we're dropping at lunch, it's a lunch. If we're dropping at supper time, it was a hot supper meal. And then cold food for so pasta salads and that kind of thing, or as something, if they had a microwave, they could microwave, so that people could stay isolated, have good healthy food, and be looked after. Of course, we're all very much aware of the rooming house outbreak in June of 2021 in Hanover, and we were taking 16 coolers of food daily down to that. And the blue is a new sentence I just added today, because as of Thursday last week, O'Share is providing meals to Chesley Place, which is currently in outbreak, and the United Way is running those meals down to Chesley to give the staff a break. And we're feeding just about 32 to 36 people daily while they manage the outbreak that's happening there. Those of you who are aware of our Food Bruce Gray app, this is the 28 months of the pandemic, and looking at what O'Share was normally feeding, which would be 1,000, 2,000 meals a month, up to the 10,000 they've been doing for the last 4 or 5 months. So this has been an incredible support, an incredible demand in our community for meals. So moving into the conversation today around mental health and addictions, and we're not an expert, we're not Canadian Mental Health, we're the United Way. We fill gaps, we work on poverty issues. You know, I've done presentations many times about what we do, so I'm not getting into exactly what the United Way does, but I'm going to get into what the United Way observes. And often when we think about mental health, it's often defined by a behavior, not a diagnosis, because the causes are varied. You can have a medical reason for mental illness, and you can have situational reasons for mental health issues. It's not always visible to the medical system, and often a diagnosis is required to access services and supports, and that can be problematic, and that can be barriering to people who need support. And we have to also consider what is preventable and recoverable from versus what needs to be managed, and what is irreversible and what is chronic. And that's where we take people at the place where they are right now and support them there. So what is episodic versus ongoing? You know, what can we change about a situation that could improve somebody's health? And how do we prevent episodic from being chronic? So somebody is suddenly experiencing homelessness because they've been reno evicted and they're having to stay with their family in a hotel. You know, that can cause things like depression, that can cause, you know, a lot of anger. And if we let that go on and on, then it becomes a chronic issue for those individuals. And coming out of that episode can be much more challenging. So just as a quick example, you know, as the episodic, this is Bob's hit a bump in the road. He has a job, manages his budget on a day-to-day, lives paycheck to paycheck. There's no savings, there's no benefits, you know, rents a house from a small landlord, but the landlord has sold the house from underneath them. The only thing he can find to rent are smaller apartments. He needs to take time off work to go look for a place to rent, so he loses income. He needs to downsize because everything is so much smaller at what he can afford, so he's got to sell a bunch of stuff. You know, he takes that time off work. You know, he may need some, you know, medical surgery due to the physical labor at work, and all of those things can really pile on a person, and you get behind in those bills. Then the relationship ends because of the stress that's going on, and now he has to pay child support, and you know, can't manage that pain very well because can't afford physiotherapy, can't afford the chiropractor, can't afford all of those wonderful wraparound things that help with pain management. And that's that episodic piece of suddenly he's in crisis because of all the things that are happening to them. And then there's Susie with a chronic issue of depression, has an employer, has benefits, owns their house, you know, budget's tight, but is manageable when they need to take a break and go on long-term disability, and then can come back to work when the illness is more manageable. Private treatment's covered by the benefit program, so this Susie's able to access a therapist within, you know, a couple of months of connecting with the long-term disability program, and is able to return to work 4 months after treatment with the accommodation that she's needed because she's got a supportive employer. So, you know, the chronic and the situational can lead to many different roads. And we think of the road as being, you know, left, right, go straight. This is what the system looks like. You've hit a bump on the road. Which way are you going? But the reality is it kind of looks more like this, navigating the system of what you need to do next. What do you need to focus on? What's a dead end? Where are the supports? Who's doing what? So some of the barriers around medical and mental health and navigating that system is we need access to primary care in a timely manner. So, you know, you go back to our gentleman with a bad knee and, you know, you can't get in, and you know, everything is phone calls with doctors these days. And it's, what is that presenting? We're depending upon the emergency department of rotating people through. And of course, emergency departments need to focus on those that have, you know, life-threatening moments. So if you're going in with a mental health issue, you can sit for hours and hours and hours. And that pandemic access to medical systems is really, really challenging. We're also seeing challenges with the adult dental programs. There's no adult dental programs. So people have, you know, pain, they have abscesses, they have all of these dental needs, and they can't get it addressed. And that affects their ability to work. It affects their quality of life. A lot of the non-prescription pain managements are not covered. So where a physiotherapist or a chiropractor or even, you know, something as simple as a gym membership would make pain management better for a person, the only thing they can get that they can afford is a prescription. So all they're getting is that drug involvement of, you know, we'll give you a prescription for the pain versus being able to afford to go to the gym, work with a trainer, and come out of that physical system and have better pain management. Caregiver burnout stress is massive during this pandemic, both sides of those being cared for, those trying to do the caring. And those nice treatments are not covered. You know, there's nothing worse than, you know, seeing the memes across social media around, you know, take care of yourself and burnout and go to the spa, or, you know, go to a movie or go to a nice restaurant. And well, that's all well and fine if you have access to a credit card, if you have access to funds to pay off that credit card, if you use that credit card. And those nice treatments, those things that would give somebody a break and really help their mental health, are just not covered by any program. So some of the barriers that we're looking, you know, and hoping will eventually be addressed is, you know, referrals to non-OHIP covered service, you know, to get faster treatment so that it nips things in the bud before it gets there. You know, the extreme poverty we're dealing with. Every Sunday, I'm out at the farmer's market with the Tailgate Soup Kitchen. And I'll tell you, 3 Sundays ago, every person we interacted with had a conversation and helped dig through the garbage bags of clothes we had a job. But the job, you know, 80–90% of the income is going to cover housing. So there's no food, there's no money for clothing, there's no money for transportation. And it was an absolutely fascinating conversation because it was the first of the month, and those on Ontario Works and Ontario Disability didn't come by. You know, we went looking for some people because we were missing them, but it was the first of the month. They'd gotten groceries for the weekend. They didn't need the soup kitchen that day, but most of the other people that came had a job. Barriers to identification. Now, since I wrote this slide, birth certificates, I think the fees being waived now for low income. So that's great, because if we get the birth certificate, we get the health card, and that's a start for accessing services and getting into applying for programs and housing and things like that. Connectivity. If there's anything this pandemic has taught us, is access to cell phones, the internet in general, access to technology is really, really important for people to manage their lives. When every application, well, just go online and do this, just go online and do that. You know, even, you know, there are moments of, okay, I laugh at all the wrong and inappropriate things when, you know, public health says, okay, do they have cell phones that we can call and do contact tracing with? And it's like, yeah, no, you know, because cell phones are also currency out on the street, in the community, in the low income community, they become currency. So it's a real challenge to address that issue. Yeah, access to safe, affordable housing. I don't need to tell you guys, anybody about this. The cost of housing, the rent, the utilities, the insurance, repairs is a major, major barrier, and it's a major, major stressor for people out in the community. We're coming up on May 1st in a couple of weeks, which is when the disconnection ban for electricity hits, and we know we're going to be inundated with people who are going to need help with their electricity bills. Transportation, cheap place to live, cheap place to be out in a motel is Chatsworth, but how do you get anywhere? How do you access any services? How do you get around the community? The GTR is amazing. And what I love about GTR is it's taking the feedback. So we now have a stop at Stone Tree, which is fantastic for that small community and that very much a low income community. They can come in for much cheaper than the $15 cab fare that it costs. But if you're differently abled and you are struggling with disability, getting around the city to all your appointments can be a barrier as well. We see some wrong agency access when people go, try here, try here, try here. We get a lot of calls like that. I heard on the street that you have, you can help me with my dental bills. And it's like, no. People hate telling people there is no service, there is no program. So they'll say, try here, try here, try here, go over there. And it's busy work. The idea is to keep people busy. So wrong door access, we've always really tried throughout our whole community to have no wrong door. So if you end up next door at the YMCA, and you're looking for food, they're gonna, they'll give you some. They'll give you some granola bars. We have some free dried food. We'll figure it out so that there is no wrong door. And one thing we've really identified, especially with the advent of our SOS mobile team, is there's no centralized case management for all needs. So the Y will look after your housing needs. We will look after your utility needs. Maybe the family health team will look after your healthcare needs. But nobody is doing the full wraparound of one person who can help you manage all this agency work that you need to do to make all those appointments and get to appointments. Because when you're low income and when you're dealing with medical challenges like this, there's a lot of appointments to be made and a lot of places to get to on a timely manner. And barriers to these requests. So there's a lot of fear in our community around mental health issues. What does it mean? The funding is siloed, it's restricted, or it's just designated. There's a big difference, for example, between a brain injury and mental health crisis, but they present the same. The underlying cause is different, but they present the same. But the funding is only for those with a mental health diagnosis. It's not for somebody with an acquired brain injury. And that's where it gets really dumb, for lack of a better word, where you cannot access services because you do not fit in the box that is the designated funding. And the need exceeds the funds available. All the time, every time we turn around, we go out and we buy toothbrushes and toothpaste. It all came in yesterday. And we, and then it's gone. Like, Wednesday market here in Owen Sound, market down in Hanover, we bring those basic hygiene needs, it's just gone. And then, okay, well, we got to go buy more. And it's the same with food. You're taking food to people and they still, 3 meals a day, people are hungry. There's a huge dependence upon fundraising to meet those needs. My organization is 100% fundraised. So is OSHARE. So is the Salvation Army. And that's who's been tasked with feeding Chesley Place. That's who was tasked with feeding everybody in Hanover, was the charitable sector. And as much as, there was some funds that came down through the pandemic response to cover some of those costs, there's still that expectation that that's who's going to look after these needs. That's who's going to support people in our community who are hungry and need the basics of life, is the charitable sector who needs to go out and fundraise. And there's a focus on emergency needs, not on prevention. So we can go to the Hanover, we can go to the Chesley and focus on the emergency, but we've known about those places for years and have done nothing to stop what's happening there. And there's a distrust of the autonomy of those seeking support. So that's where that application, that means testing comes in, is, well, what are you going to do? What are you going to take this? If I give you a cell phone, are you going to sell it? Are you going to use it to find housing? What are you going to do with it? So we don't trust people very easily. And the complexity of our need is growing and the level of need is growing. The housing crisis is driving everything we're seeing right now, because you can't find a place to live. And if you find a place that's open and available, you cannot afford to pay for it. And our agency programs and capacity and connectedness is really stretched right now. We're going 2 years in, over 2 years into this pandemic, we're exhausted. The charitable sector is exhausted. We don't have redundancies in staff because nobody, or fundraise, nobody wants to pay for staff. So those are the challenges that are hitting our agencies and our capacity right now. So what are some of our solutions? Because, I won't leave you without a solution. Universal basic income. It really can assist with both episodic and seasonal mental health challenges. So there are people who are functioning great spring, summer, fall with the sunshine out there and the warm temperatures. They're absolutely able to work, but winter hits and it hits them hard and they cannot work. A universal basic income allows them to deal with those seasonalities around mental health challenges. And more in community supports that meet people where they're at. And SOS is a great example of that. It's just, what's going on? What can we help you with? What can we get you connected to? And what barriers can we lower or just throw away? And it's a great example, and there's great reports coming out of that. So that's basically my little overview of the issues from where we sit, what we see, who we are, and what we do, and what some of the challenges are that we're desperate to work with all our community partners to solve. Happy to answer any questions.
Questions for Francesca? And clerk, you'll have to help me out if I'm missing one. Kim, go ahead.
Thank you, Mr. Chair. And not a question as much as a as a comment, and just a huge thank you, Francesca. We've said it at council, and I'll say it again today. There is no way that the county could have been as effective as we were, in whatever small way that turned out to be, through this whole pandemic, if it wasn't for the tireless work of your team, of the people at O'Share, of everyone at Salvation Army. It's incredible. And for those of you who weren't part of the traffic back and forth on any given day, 7 days a week, 24 hours a day, there couldn't be a better example about how it takes a village to support everyone. We had people on their own time, on their own buck, driving all over the place, doing so many things for so many people to try and keep them safe and to keep them comfortable in very, very difficult circumstances. So I know that you're seeing this stuff on the front lines every single day, Francesca, but I just, on behalf of everyone, want to really acknowledge and thank you and all the people that work with you every day. You do amazing, amazing work, and we're so grateful to you.
Thank you. And I should have acknowledged that we have 22 food banks, 9 meal programs, and I think we're up to pile of gardens and things like that. So we're just part of a huge team of people who are looking to support our broader community because it's our home.
Francesca, I had someone at a conference that I was just at say something to me about the employment in Grey Bruce. And he made the comment, if there's anyone not working in Grey Bruce right now, it's because they don't want to work. What are you seeing out there in terms of employment? Like, I know housing is completely taking over. And is there more work out there for some of these people, or are they still struggling for jobs?
Being employment ready is a really important part of that conversation. What are the jobs available? There's a lot of exploitive work out there. Some of the people we talked to when I alluded to the past Sundays ago, it's cash under the table. So, is it a good job? Is it a living wage job? Those that are working and they're working minimum wage, 80 to 90% of what they bring home is going to their housing costs. Right. What's the childcare situation? So when you think about all those fast food places that are looking for staff, if you don't have evening childcare, or for those that are open overnight, that's a real challenge. So if you've got a lot of single parents, and you've got a lot of people that are not interested in that type of work. There are people who don't like people and don't want to deal with people, and the introverts of the world. So if that's the jobs that are available, and those are the folks that aren't. So there are jobs available, but what kind of job? And what's the, you know, is it full-time? Is it seasonal? You know, we hear that a lot of, you know, I quit this job to go over here, and then suddenly everything changed. I was promised this, and that not actually didn't happen. So there's a lot of distrust between employees and employers as well. And there's a lot of people dealing with a lot of medical issues. You know, I know, talk to people at the Wednesday markets that are interested in working, but they can't stand. So they want a seated job. So do they have the computer skills? Do they have the patience and ability to learn? What's the productivity expectation of that job? You know, there's a huge amount with computers and everything that our productivity has gone through the roof. And if you're an older worker with physical limitations, so you want to sit and run a computer rather than running around lapping coffee, what are those barriers to that type of job? Does the, you know, that job mismatch? We hear a lot about that skills mismatch, and I think that's driving a lot of it as well.
Right. And I was I was taken back by the statement, because there may be jobs available, but you know, you need to be educated to a certain point for some of these jobs. You need the skills to have some of these jobs, and it doesn't always help the people that are not educated and looking for work. So, and
that's where those wraparound pieces come in. Is a housing first strategy. You get somebody settled, you get them to trust that there's going to be food every day, and that the roof is there. And only then, you know, it's Maslow's hierarchy of needs, right? Once you start moving up that triangle, and you know, you can breathe, and you can manage, then you can start looking around and going, okay, what's next for me? What is it I'm interested in doing? And flipping burgers may not interest you in any way, shape, or form, and that's okay.
Okay.
I keep seeing Scott. Scott, I can see him in the corner. He keeps waving his hand.
Go ahead.
Thanks, Mr. Chair. I must be out of your line of sight. Francesca, thanks very much for your presentation. And as Kim mentioned, a sincere thanks on behalf of the residents of Grey County for all the work that you're doing. I was interested in your comment, a couple of your comments. Glad to hear that the Grey Transit is working well. It's good to get that feedback. It has been a big investment by Grey County, and I'm pleased to hear that it's working for a lot of people. Your comment around centralized case management and that ability to help people navigate the system. How do you see centralized case management coming to play? You know, it is a very fragmented system that we have right now, and I do believe the centralized case management would solve a lot of those issues. But how do we get to that point?
I'm not really sure. Like, you know, if I could run the world, give me 5 minutes. You know,
for a day.
I think, you know, in my world, it should be based on what the presenting issues are for those folks. So if somebody has a mental illness or a physical illness that has an organization that wraps around it. So maybe somebody has COPD, so heart and stroke would be a great example. So if there was a primary organization, so if the person's primary issue is housing, so then the Y Housing has them as the primary, because without creating a whole brand new agency that then becomes everybody's navigator. So to me, it would be their primary focus, whether it's physical health, whether it's mental health, whether it's a housing issue, whether it's schooling, so the Adult Learning Center, and then they have one primary person who can then help connect out, and then we kind of share the burden more as organizations as well. So it's not all just shoved off to, oh, you know, we'll just send everybody to Safe and Sound that's dealing with housing crisis, but they may have cognitive impairments and have a caseworker at community living. So their community living caseworker should be their primary. So I think it's a lot of, and I know Phil will probably have things to say about all that too. You know, that's how I'd like to see it, is more spread out as with people with a primary versus a centralized organization that suddenly has to go out and find, you know, 30 social workers who then, you know, have to navigate because everybody goes, good, here, you take them.
Okay, thank you. Any other comments, questions?
Mr. Chair, I see CAO Wingrove and Warden Hicks.
Okay, go ahead, Kim.
Thank you. And just to follow on Francesca's thought, some of that coordination and system navigation was kind of the premise of the way the family health teams were originally envisioned, where there was a primary care provider, but then there was also a whole team of people associated with that model that was meant to really move people through the system. And in some ways we've kind of moved away from that, or didn't really realize that entire vision, but there may still be a place for that, because certainly from the county's perspective, we have a relationship with people who are receiving benefits, but as Francesca said, there are many people out there who aren't on benefits. We don't have a particular relationship with them. So
I will also highlight Southeast Grey Community Health Center is one of the best examples of doing that wraparound. And there's a little part of me that when somebody's got complex needs and they say, oh, I'm in Dundalk or I'm in Southgate, I'm like, yes, Jeff, Tanya, Crystal, I got people who can do that wraparound. And then I get that feedback, a couple of days later, they've talked to Jeff and Jeff's like, I need this, and this from the United Way. And I need this is, and we can do that. And they're a great, incredible example of doing exactly that.
Okay, Mr. Warden, you have the floor.
Mr. Chair, my question is for Anne Marie, and I don't want to put her on the spot, but maybe I am. With this coordination subject and with the transformation of social services by the province, taking over the administration, our workers being able to do more traditional social services sort of a role. Is that going to help with this issue? And if it is, can you tell us how you anticipate it will be of assistance?
I think we have a number of opportunities that are presenting themselves through some of the modernization efforts through the province. With the social services modernization, you're looking at our workers providing stability. Again, I think more of what Francesca's talking about is that primary care coordination and case management. But certainly we would become part of that role. And as Kim mentioned too, there are a lot of people that don't get benefits through us. They may not necessarily have access to that stability worker. The other part of that is our homelessness. With our by name list, we do have a coordinator, and we are looking at providing some case managers in the near future. We have received some new funding, so that will be assisting, and more towards that outreach, more towards that helping assist the Sos Mobile. But again, we're not that primary care structure that county just doesn't provide that, but we can certainly work and enhance what's out there with the resources through the stability worker.
Yeah, Mr. Chairman, I was really taken by Francesca's slide that showed sort of the highway thing, with the snakes leaving, and someone with a multitude of challenges trying to navigate that world. It's almost like you need a navigator, somebody who's going to say, okay, I got this thing figured out. This is the way, and here's how you avoid the landmines, I suppose. That when I see that, I go, yeah, I get it. So Francesca, thank you for that, because it helps one to understand that, you can't take sort of a client with one issue in isolation. There's a multitude of things that need to be addressed, and just figuring out where to start and trying to navigate that world on your own must be overwhelming for certain people.
I think one of the
It certainly is, and sorry, Councillor Leary, I was just going to say, I totally agree with you, Solomon, and I really like Francesca's idea of having that caseworker. So if you've already got a worker involved in your life, then that is the person that you've already built that trust with, and they should have that autonomy and that knowledge of the system to open those doors for people. And I think that's where that coordinating a whole system works. It doesn't necessarily mean we need to hire all of these caseworkers, it means we need to rejig what we've got so that there is some sort of coordinated access, so that everybody's talking the same language and knows what systems are available and takes ownership and responsibility of the people that they have on their caseload.
And that's I'm going to just jump in here because I can. That's really key. And that goes back to training, because we all come with biases, assumptions, and stereotypes. And if you're a bootstrap kind of, especially, you know, I've made it, why can't you? And you really rely on somebody, you know, because you want to teach them their own autonomy and to stand on their own. But you got to be careful they're not too far in the deep end and that they simply drown, and maybe they need a little more support. And, you know, having staff that understand ebb and flow, and accountability comes in it to people as well, because sometimes when caseworkers hold you accountable for decisions and, you know, making appointments and keeping appointments, you know, that relationship can be a bit rocky, but it's like, okay, and you just keep coming back to the starting point and then moving forward again. And, you know, it's like going through detox days 6 to 10 times. You know what? Okay, today's a fresh day. Let's start today fresh. And that's hard.
Thanks. I just wanted to comment on what Bucket said. When you said, I get it, I think we all get it, because I think we've all been, when you look at those roads going all over the place, I think we've all been there. The difference is we've all had the luxury of saying, you know, we're living above our means. We can cut here, we can cut there. We have family support to help us out. The people Francesca's talking about are the people that are treading water to begin with and have nowhere else to go and nowhere to cut. And it's a good reminder for all of us. Okay, any other questions or comments before we move on?
Yes, Mr. Chair, you have Councillor Clumpus and then Ms. McClay-Winters and Ms. Umbach.
Barb, go ahead.
Thank you very much, Mr. Chair, and good morning, everyone. Thank you, Francesca, for a fabulous presentation. Very, very discouraging, of course, but certainly we all have to understand this and have it come back home. A couple of new expressions that I learned today that I really liked: differently abled. I love that. That's much more appropriate, and no wrong door. So to be using that in our community safety and well-being tasks there. But you did mention access to primary health care as being a barrier. And of course, we all know the difficulties that we have in our area with attracting physicians. In our area, we have been underserviced according to the provincial mandate since 2007. And we haven't been able to attract physicians for the simple reason because now they are looking for a much broader interaction with allied professionals, i.e. the family health team organization. And it is very, very difficult with, excuse me, I haven't talked much this morning, with the lack of provincial funding for new family health teams. This is something I think that really needs to be paid attention to, because those allied professionals working in family practices could perhaps be that navigator, if you will, or that assist with these patients coming in, that could help build that trust as well. So to speak again on a follow up on Kim's comment about the family health teams and how they have, the concept of them was excellent as a starting place to provide access to primary health care. But that, I think, is absolutely critical to providing a road through to help folks that might get missed elsewhere, just floundering in the community. So thank you again for your very, very thorough presentation. Certainly hit home. Thank you.
Thanks, Barb. Sorry, Heather, I had Jill marked down, but who is next?
Sandra McClay-Winters.
Okay, Sandra, go ahead. Sandra, you're on mute.
Yeah, I know you're not on mute, but we can't hear you, Sandra.
Oh, she's not on mute.
No.
It's the headset itself muted.
No.
Type it in the chat.
Okay, she'll type
Okay.
it in the chat, and Jill, and then Ms. Vauden also has her hand up.
Okay,
Thank
Jill,
you.
go ahead.
I just wanted to say, to support some of the things that Francesca was saying, a lot of the people that we're working with are not in, as you say, Brian, a position to be able to plan, to be able to even make decisions. When you're in that perpetual crisis mode, it's very difficult to even map out where you're going to go or who you're even going to talk to. So I think that point of first contact and that trust factor, I can't emphasize enough. And I think that came through very strongly with Francesca's presentation, that, to get somebody at that moment to say yes to something is an incredible relationship of trust, to say, okay, today I'm going to do it, and then to turn around and access that services. So there's a timeliness to all of what Francesca's talking about. You can reach somebody at some point with a bowl of soup and they say, today's the day I'm going to do something. Or it could be that today's not the day. So I think that our ability to plan for people is always imperfect because people never plan that way. So even the best laid plans for coordinated access can all go, fall apart when that person that day just can't cope. So it's that multiple approach. And that, as Francesca said, once again, the no wrong doors is so critical, because you don't know who's going to be the one person they trust that says today, yep, I'm going to accept what is being offered.
And that comes back to a point around Sundays. So the women of Nashing started the soup kitchen on Sundays back in November. And we realized during these cold alerts that always happen on the weekend, nothing is open. And if you didn't have the vaccine passport because you didn't have the ID, you may be fully vaccinated because of the SOS team. But if you can't sit at Tim Hortons because you don't have the documentation and don't have the paperwork, on Sundays, I had nowhere to send a hypothermic homeless person. And, we all need a couple of days off. It's not about, just pigeonholing everybody, you got to work 24/7. But we've got to layer our support so that when that person that does come and has a bowl of soup and starts telling a story and you're like, oh, I know exactly, what we need to do here, go to Safe and Sound on Tuesday might not be the right answer. So these are all the things we're identifying. It's a big hill to climb, and we got amazing partners working on all these things.
Great, thanks. And good points, Jill. Just before I go to Naomi, can I check with Sandra to see if she's available to talk yet? We'll try. No? Not yet. Okay.
So, Mr.
Naomi?
Chair, she has added some information into the chat.
Okay.
Francesca's presentation was focused on persons with mental health. However, the same barriers presented apply to those with substance abuse disorders as well.
Right. Solid point. Okay, thanks for that, Sandra. Naomi, go ahead.
Hi, can you hear me okay?
Yes.
Okay, thank you, Francesca. That was very interesting presentation, and I agree wholeheartedly with your thoughts. I did want to just highlight the designated funding. I do find that is a real barrier, and it's not too much we can do about it, but just in terms of lobbying at higher levels, just bringing that forward. When you have very strict designated funding, it really ties all of our hands. And I'm sure Phil and Clark, especially in mental health, they have these little narrow buckets and there's these little narrow targets, and they don't always lend themselves to what we may think is best. And that is a challenge. And I think we're all very good at bending and weaving as best as we can, but it is an issue that I just want to reinforce. The other thing I just wanted to bring forward is staffing. Staffing in our sector is very, very challenged right now, like I've never seen before. We may have one applicant for a position or no applicants for a position. And so to continue to provide service or is challenging. And I think that where the county can help is what we've already talked about, housing. Often we'll get applicants and then they won't move to this area because they can't find reasonable rental facilities or housing of any kind. So it's growing. It seems to be getting worse. And I think, we've done some job fairs, doing more widespread job fairs, the buses that you've done to bring people here, all these things are, I think, really, really helpful. And then somehow to get the infrastructure in our area to bring these staff to be able to come here and work and have even short-term housing while they're looking for a longer-term housing arrangement is really critical.
So I want to reflect on Naomi's and then I'll shut up. Anne-Marie and her team, absolutely incredible with housing the homeless over the last 2 years. And a motel will charge $2,400 a month for that hotel room. But we can't take that $2,400 for 1 month of housing and turn it into a $200 a month rent subsidy and stretch that over a whole year, because the funding is restricted to emergency housing. So we'll pay $2,400 a month to keep somebody housed for 1 month, but we can't take that and stretch it out to reduce somebody's rent to an affordable level. And that's where we run around and start muttering stupid, and everything is just stupid.
Okay, that's to the point. How are we doing here, Heather? Are we caught up? Any other comment?
I see Councillor Mackey with his hand up again, and then I think that is the last one.
Okay, we'll do one more. Scott, go ahead.
Thanks, Chair O'Leary. Very interesting conversation, but it leads me back to Warden Hicks' comment about the snakes with all those different off ramps. Is there a menu? 211 I know is a great resource, but there's a lot of staff out there that are probably doing that case management. Is there a one go-to that shows a roadmap or shows a menu of all the different services? If you've got a youth or an adult with one presenting problem, is something to look at to say, oh, you go here for that service or you go there for that service? Is 211 the only one we've got? Or is there a better way that as a region, we can educate all those people that might be doing case management?
So 211 is the grocery store. What we're missing is the recipe. So somebody can go in the grocery store, look at all of that food. If you do not know what the recipe is, you do not know what the ingredients are, if you can't afford the spice that adds just that extra kick to what you're cooking, it's just a grocery store full of food. And that's what 211 is. 211 is a listing of all the services, but if you do not have the capacity to navigate that store, then you don't come out at the end with a cohesive meal, using this really bad analogy that popped in my head. But that's what we have. We have the listing. That 211 is brilliant at making those connections. They can stay on the phone. They can help people navigate that system, but they cannot walk through the door with that person and advocate on their behalf. And, the people that want the help and suddenly feel self-conscious of walking into a family health team full of middle-class people with middle-class strollers, and they got a couple of kids who are just hungry and they're hangry, and they just turn around and walk out because it's just not their world and they can't manage it. So we've got the grocery store that is 211. What we have to create is the recipe cards for people, and then have some personal shopping.
Great. Okay, we have to get moving on here in the agenda. Francesca, thanks so much for everything you do, and thank you for the presentation this morning. Number 4 on the agenda this morning is Jill Umbach from the Poverty Task Force. Good morning, Jill. You have the floor.
I'm just going to share. One moment. So I'm not going to repeat everything that Francesca has said, and nor are we going to, I totally support. One moment, and I'll just make sure my presentation is in slide mode. Okay. There we go. many of you around the table already know about the Poverty Task Force. We are an organization of over 52 partners that have come around the table. Many of those partners, Francesca has just spoken about how we've come together in terms of the emergency response. We, as the Poverty Task Force, spent a lot of time in terms of the coordination and communication and looking at what were the gaps. So for the last 2 years, and we've been looking at how to respond to emergency, but that emergency response and what Kim spoke to in terms of that coordination really has come from the last 10 years of working together to look at food security, housing, income and employment, transportation, and health equity issues. So a lot of the established relationships that we've been building on have allowed us to do a lot of that rapid response coordination. We've also been able to deepen, and we do have a lot of references around precarious living, how that impacts on your mental health and well-being. At the Poverty Task Force, we are an action table of the Community Safety and Wellbeing Plan, and we're also a member of the Community Drug and Alcohol Strategy. A lot of the people that we work with are the same people that you all around the table often see on a day-to-day basis. So we know that mental health and addiction crosses across all of the areas that we're working on, whether it be addressing housing and homelessness, or whether it be seeing people at the food banks and community meal programs. Collective impact is what we need to do and what we do. We developed for 2022 some of the things that will support the work that we're all doing, but trying to come across and do it more collectively rather than individually. So Francesca spoke to some of the solutions and recommendations for going over the barriers. A living wage campaign and a basic income are two of the priorities across all of the sectors that we're seeing in terms of people's ability to afford rent, people's ability to purchase healthy food, people's ability to even get out there and participate in society. One comment that Francesca made with regards to jobs and availability, they are available, but are they jobs that will be sufficient to be able to house your family, to feed, and then also keep you safe? I mean, the big elephant in the room is people are still leery about COVID and being on the front lines. A lot of people have stepped back from that. So we have lots of programming that's going on collectively. What I wanted to share with you today was just some other contributions that we've been seeing in the last 2 years, and other contributions we can make to the larger conversation for the Mental Health and Addictions Task Force. Harm reduction approach. You know, 2 years prior, I know that the Community Drug and Alcohol Strategy was working on how do we roll this out. We've spent more time at the Poverty Task Force educating community members around what is a harm reduction approach. That's been a large part of the work that we do. And so some of the calls to action that were made by the Community Drug and Alcohol Strategy, we strongly support. And that is a coordinated multi-sector, multi-level response based on the lessons learned in the last 2 years. There's a lot of interventions that we know about that can prevent fatal drug overdoses. Our community has been heavily impacted, and certainly the members around the Poverty Task Force have been devastated by the number of deaths of the people that we work with. Those are a large number of those are street involved, but then there's a lot of hidden challenges with people, and we've seen families and people in our community die where we were totally unaware of the challenges, barriers they're facing. Yeah.
I don't think for on my
nobody
screen,
can see.
Screens aren't. Well,
I'm so sorry.
Because I think you're probably on your.
I have it on share.
It's not advancing.
It's not
Jill.
advancing.
Oh, it's not advancing. Yeah. Oh, of course.
You're on the PDF. You're not on the PowerPoint.
Okay, one moment. I apologize. So sorry. One moment. I'm trying to go back to my.
Great presentation. I just didn't want to lose all the impact.
Yeah, I am so sorry. Let me just go to PowerPoint. Of course.
I have it on my computer, Jill, if
Can
you'd
you
like.
pull it up, Tara? And my
Sure.
sincere apologies. It's not actually in PowerPoint, it's in Canva, and I apologize for that. So Tara, if you could, I will. Are you able to share it? Okay. So if you can just scroll ahead, yeah, so this is background information that you can look at afterwards. If you go to the next screen. There, and my sincere apologies. What I was speaking to is sort of that harm reduction approach and moving it out more into the community. And I think the increased harm reduction outreach services to support community food and housing programs on the front line is something that we've been actively working on in the last 2 years. One of the things that happened at the beginning of the outbreak is that a lot of the programming shut down because staff were isolating in lockdown and things like that. And at that moment, we were saying, this is the time when we actually need more of it out there. And luckily, everyone heard that cry and the teams came together and started putting out more harm reduction, both in terms of supplies as well as education. We also would recommend that recognizing the trauma and the grief that volunteers and staff have been experiencing and have had to continue working through under the pandemic in the last 2 years. We've seen an increase of overdoses and deaths, and it's been hard hitting for the staff that are coping. We saw that happening with our 2 Indigenous reserves where, Saugeen and Nawash were really overwhelmed with some of the trauma and a lot of the support that came in wrapped around. We need to consider and keep going with that. We are still seeing people traumatized and impacted, people at Safe and Sound, people at Saugeen, people in other locations. We've got to recognize that that is also part of it, the health and well-being of our outreach workers, whether they be, some of them are just, volunteers working in the food banks, others are actually the trained professionals, but we've seen a lot of that. Indigenous harm reduction principles and practices also need to be integrated into our policies and practices. And that's something that's coming out of Nawash and coming out of Saugeen, but also at Mowicadom Indigenous Friendship Center. They're really having to reach out and look at other ways in which they engage with our community to meet the needs of the people they serve. Next slide, please. One of the programs that we have been operating for the last 10 years with support from Grey County and Bruce County has been the Getting Ahead program. It's an 8-week program. It works with individuals to examine the stability and instability in their lives and how to build resources. So Francesca and everybody around the table was talking about the fact that many people haven't stabilized their lives yet. So that's that housing first model, where first you build a certain amount of foundation and then you can move forward on other steps. And some of those other steps may be more mental health and addiction supports or more physical health supports for better well-being. Some of it is housing, some of it is actually starting off with the mental health or addiction support first. And then that might work backwards to assist them in staying in supportive housing. In the program, 289 people have graduated from that program in Grey County. A large percentage of them would be single moms, dual diagnosis, on OW, ODS assistance, and a lot of them coming from generational poverty. So a lot of the work that we need to do with them is both stabilizing them from a housing perspective, from the basic needs. It may be income, but a lot of it is identifying how they can access the mental health and addiction supports. One of the challenges that has been identified by the group has been no local residential addiction services for women. And in particular, women are very, very concerned about accessing services if it comes at the cost of parenting their children. So when we're seeing a lot of single moms with kids, a lot of them will resist, will not access some of the mainstream services, because it may mean losing their children. So certainly the social stigma of being a bad mother, having parenting with an addiction, going through all of those programs is fantastic if they can access it. A lot of people without the private insurance face high costs, so they have a longer wait time to get into some of those services. And I mentioned before about trust. It takes longer to build trust when you've got children and family and community involved. And when you're a mother and you've had to be involved with the Children's Aid Society, you've had to give up your children, possibly, hopefully for kinship placement, but in many cases foster care, in order to seek treatment, in order to have and overcome some of the mental health and addictions. And it's not just a one-time experience, as Francesca and others have said. This is a roller coaster of life. So many people will have challenges. It won't just be today. It will be possible relapses. But when you've got children and family involved and you're the only caregiver, there's a lot of burden put on women. So just an emphasis when you're looking at any of the new strategies is to consider the gender lens and the challenges for women in our community. Next slide, please. The other lens is some of the things that we've heard from our Giwe sharing circles, which is it's a housing, started off with a housing sharing circles, taking an Indigenous-led program, Indigenous-led perspectives, and working on how we strengthen our relationships and how we work with our collaboration. So this has been actually a very good and a best practice for a lot of the work that we do with housing. We've now translated that as well into a new Giwe Youth in Transition support program as well. So looking at some of the partners that work for youth in transition. Some of those focus on youth in care with the CAS, and some of them focus on youth in the justice system. One of the things that we have heard in this sharing circles has been the intergenerational trauma layers all of the mental health and addiction issues. And so from Mawikidon, we've heard that an Indigenous trauma-informed counselors and staff and approach is needed. And I know that Mawikidon is working on that, and you'll probably hopefully hear from them in more detail at another task force meeting. But more trauma-informed training is needed for Indigenous staff, and that's something that's been identified by the Mawikidon staff themselves. They need to be able to provide safe spaces and traditional land-based spiritual counseling. They do connect with some of the Indigenous treatment centers, and there's referrals back and forth. Indigenous harm reduction is also something where they need to be able to look at that perspective and how to offer it. And that would strengthen the current harm reduction approach that we have for our area. The other aspect is for our non-Indigenous organizations, for us to be able to examine and address systemic racism. And that is heavily discussed within the Giwe sharing circles. And it's something which is a priority as to how do we see some of the barriers that are a little bit more subtle that prevent people from accessing our services. Next slide, please. Sos Mobile Outreach, as many of you are involved with that. It's a collaborative response, starting with the COVID outbreak that we had in the rooming house in Hanover. And there's both the stationary and the mobile outreach. And so building on that, our recommendations and what we've heard is, and we've heard a lot in our discussion with Francesca as well, is we need more person-centered approaches whereby each person who's going to have to go through that snaky roadmap is not going to follow the path the same way. They are not going to resonate with exactly the same path that the person next to them is. They're going to have to prioritize what they want to address first. Some people, it may be their physical health before they'll actually look at their mental health. Others, it would be providing housing stability, and as Francesca said, prevent some of the chronic and try and reduce the episodic. We know that there's more funding is needed for the SOS Mobile Outreach. We know that to ensure that the system is there, we also need, the SOS team is making referrals. They will engage with people. They will then want to be able to hand off. So again, in terms of that transition or handoff or warm referral, we know that the mobile outreach team can't be the case management team. So we need to look at that, smoothing out that transition. Who are we handing off to? As Francesca may have suggested, maybe it starts with the housing and that caseworker stays along with them. Certainly Southeast Gray's community health center model is something that we at the Poverty Task Force would certainly endorse. We've seen the model in discussions at our health equity action groups as that wraparound support, but they also have the medical response combined with the other needs. So we need more case management resources to not only provide supportive housing, which I believe is different, very different than supported housing. We also need more coordinated access and navigation to services where we know that there is wait times. So what happens when you get a referral to a service, but it could be 6 months before you can access it? And I know from hearing and listening to people at Safe and Sound, quite often this is what happens. So the next step is to go here, but that next step is 6 months. So what do we do in the interim while they're waiting for a placement, say in a residential care, or they're waiting, or they've just been discharged from an institution? So we are seeing a lot of discharging from both hospital, from jails, from treatment centers. And then there's a huge drop afterwards where we're not picking up and supporting people after that. So the aftercare and the transition back to the community is there's a huge drop for many, many people. And we at the Poverty Task Force and amongst the partners get a lot of calls, literally the day before, so-and-so is being discharged tomorrow. What are they being discharged into? And I know that Naomi and her team, we get calls for them saying, well, where are we going to put them? And where's the aftercare? And who's going to do that? So coordinated access, but also the navigation after you might have had a treatment. And as Francesca has highlighted already, that more resources and service extended for Sundays and evening coverage. One thing Francesca hasn't managed or mentioned rather is 211, looking at some of the after hours coverage and the weekend coverage. But once again, it is something that may or may not be able to respond with who's open. So you could get the call, to respond to somebody on a Sunday, but then who is open? And then how do we hold somebody to Monday without losing them? So those are a few things from the Poverty Task Force perspective and that supports the larger picture of how can we do more for the people in our community.
Thanks, Jill. I just wanted to ask about the evidence-informed interventions. Can you just talk about that? I know it's relative to overdosing in drugs, but can you talk about that with alcohol addictions as well? Does the intervention work, and where does it come from?
I will be honest, I can't. But Alison Gauvier and others are the ones that are actually bringing that forth. So we know with harm reduction, and we know the experience that the United Way has had is, you can't, a lot of the COVID isolation that was happening with people that were are dealing with alcoholism and other aspects, they have to have the harm reduction materials with them. They have to continue. It has to be done in such a way that you don't have people dropping dead on you because you've cut off their supplies and things like that. So I'm actually going to throw it to Alison, if that's okay, Alison, because she actually has more of that evidence-based material and research and knowledge in her head than I do.
Okay, thanks. Go ahead, Alison.
The evidence base is founded on the premise that drug use is a part of life, and that as service providers, we don't have control over whether someone uses or not. And so all of the interventions that are offered through harm reduction are just about how to keep someone safe. So for example, if, clean equipment is offered to someone who is using that may prevent the spread of disease. So that would keep them a little bit safer than they would be if they didn't have that clean equipment. It's really about what is the goal of that person, and how can we wrap around that person to keep them as safe as possible. And that could look like all sorts of different things depending on the scenario. I'm happy to open it up to other folks on the SOS team who are involved in the frontline service provision. Go ahead, Clark.
Yeah, I think, with harm reduction, I think it's important to talk about some of the underlying assumptions and values in it as well, because I think with harm reduction, there is an understanding, or with pursuing that, there's an understanding that the addiction arises out of trauma, not of any lack of moral fortitude or anything. So we find within the provider community, there's a great comfort with a harm reduction approach. But as you move out into the general public, there is a resistance to it. And there's a spectrum of harm reduction approaches as well. So at the one end, it is simply providing people with clean needles and their supplies and naloxone. And then at the other, as we move up, it's the safe supply, where we're moving into prescribing medical grade opiate as opposed to the street drug. So it's not it's taking someone who is using what could be compromised drugs and providing them with clean medical grade opiates, not judging them for using, but simply providing them to keep them, as you say, safe. So it's really one of the things with, when you mention the harm reduction, that what we have to work on, I think, is getting people to understand why we take a harm reduction place. We're not promoting drug use. We are acknowledging and accepting that people come to use or come to acquire a substance use disorder because of trauma, not because of a moral failing. So, as you move out into society, you really do get quite a strong pushback on that, because people don't understand. And we need to break through that if we're going to really address the problem, because it is a longer term. As remember, one of our first meetings said, we're not going to simply fix people. It's much more complicated than that.
And I would add, one of the challenges, and that's why we're seeing it, and one might say, why are we talking harm reduction approach at the Poverty Task Force, is because people are having experiences at the food bank, at the community meal programs, now at the SOS, but we were seeing so many places, and a large number of these places are run by community volunteers, largely seniors. And they were just like, starting to set up barriers that said, we can't deal with so-and-so. If you have to be clean to come and access food. And that's just not the approach that we want when it comes to providing basic needs. So there is a big challenge in our community to take it out into the groups that are on the front line, that are not trained social workers, that have not got a background in that. So there's a lot of education and awareness that we've been doing for the last 2 years around it. And then also, as I think, Clark would support that. Well, what happens when someone's in trouble in front of you? And how do you access the services then for somebody who, it was scary at the very beginning for some of our food banks to even have naloxone kits. They didn't want to have, well, what if I have to use it? Well, what am I going to do around this? So the training and the education around some of the basics, and that's not even getting into, does this person deserve our support? Because there's still some charity models out there that still talk about, those people We'll feed this population, but not that population. So that's a lot of the discussions that we have around taking that harm reduction approach, as both Allison and Clark have spoken to.
And you know, that attitude of those people is one that I think we can all fall into. And underlying this is really that sense of the other. And what we are all talking about is breaking that down and seeing these people on the margins as part of our community, and having a place and a right to be there, and opening up the community so that they can actually engage and what's needed. You know, they need food security. They need to be lifted out of poverty. Sorry, Allison, I think I jumped in. You had your hand up.
I would just say, before Allison comes in, the safe spaces is a real challenge under COVID, and has been under the pandemic. Creating safe spaces, which will also not do harm to the staff as well as to everybody that gathers in the safe spaces. And I know that Safe and Sound has had that challenge with offering safe spaces, but then also not becoming a place where people will actively use and or put other people at risk. So there's always this challenge that we sometimes have, and we have to name it sometimes. If you've been banned from the known safe places, where do you go? And that's some of the people that we're seeing at the Sos Mobile stationary place. Where do you go when you have been banned? When YMCA housing and our homelessness program says you can't be in these motel rooms anymore. So we still have that outer fringe of people that have challenged our safe spaces to remain safe. And I think Mawickedon Indigenous Friendship Center is a new safe space, is what they want to start creating, that takes a more holistic, includes people in the community, includes people in and some of the healing from an Indigenous perspective that is needed to address the trauma.
Allison?
I just wanted to highlight a point that Jill and Clark had touched on, and the underlying idea that whether or not a person uses substances, it should not affect their access to treatment or basic needs or basic services. So that is the underlying premise of harm reduction. And like, we provided some harm reduction training through the drug strategy last October. And there were folks from all different sectors who jumped onto that. It was a 6-hour training. It was pretty in depth. And it wasn't, sometimes you think like, oh, I'm not a nurse. I'm not, I don't work in addictions. This training isn't necessarily for me. I'm not giving out harm reduction supplies and needles. I don't need to educate people, on the equipment. So this training doesn't apply to me. But actually, this training applies to everyone. The librarian, the person at the front desk at the city, any public facing employee at any organization, really, because it teaches you how to create safe spaces for people who may be using drugs, and in turn, how to create safe spaces for the staff as well, so that those barriers get taken down so that people can access those basic needs. So I really do encourage any of the municipalities, counties, agencies, if you haven't already provided harm reduction training to your staff, I'd be happy to make some connections for folks.
Great, thanks, Allison. Any other questions for Jill? Okay, Warden Hicks, go ahead.
There we go. Sorry, Mr. Chairman. I was going to make a comment. I think I'd be interested in data about the connectivity between mental health and addictions. Not everyone with a mental health challenge has an addiction problem, and maybe not everyone with an addiction problem has a mental health challenge per se. But I just wonder, is there data that speaks to that, connectivity? And why is it that, anyways, just in my head, how come it is that some people have both and some people have some? And what is the data around that? I mean, this is a task force on mental health and addictions, but I would love to know more about the connectivity there. I was very interested in the piece that goes back to childhood trauma. That's informative, but I just wonder if there's anything else there.
That's right.
Clark?
And no, Dr. R had his hand up, so I'll put
Go ahead.
mine.
Thank you. Through you, Mr. Chair, a very excellent question, and definitely mental health is a risk factor for substance use. That's well established in literature. And if I can circle back and connect it with the previous question from the chair, evidence-based practice, it's a term that was coined by a researcher from McMaster around 20 years ago and has been used throughout the world. It's totally specific to the task at hand. And whenever you ask for evidence-based practice, which is a very good question for this task force, if we're going to fund a certain initiative, and we have on the table 6 or 7 initiatives, it is definitely the best practice to fund the ones that are proven. Evidence-based practice in 30 seconds is looking at a population of individuals, whether it is a community or sub-community or group within a community, looking at the condition you're looking at, whether it's substance use or mental health or specific substance use, and looking at the intervention, aligning these 3 and looking at the results. Is there actually benefit of that intervention? And in that process that is scientific, you discount anything related to values, anything related to perception of the person who's treating, or any biases. I want to do everything for everybody, but my bias would lead me to believe that everything I'm doing is actually benefiting people, versus when you run it through the algorithm, through a research, some interventions are going to be useful, some interventions are going to be less useful, some interventions will be more useful. So evidence-based practice is that a rigorous scientific process that's supported by peer-reviewed. Those are the keys that a person would look at: peer-reviewed research. If it's proven for a specific population, specific intervention, and what the results are. And usually you'd find the number needed to treat. That's a single number, and usually it is between 1 and thousands. If you treat 20 people and you prevent death in 1, the number needed to treat is 20. So that's to say, every time you apply this intervention to 20 people, you get 1 prevention, 1 death prevented. And the smaller that number, the better the intervention is, just in terms of background about that. But back to the question, there's mounting evidence in the literature that mental health is a predisposing factor for substance use. Why there is variability? Because you look at the social determinant of health, there are multiple factors affect the health of individual. So somebody might have mental illness, let's say depression, and they're exposed periodically to treatment. Some of this treatment might cause addiction. The condition itself might cause addiction, but the person has very strong family network, very strong social network. Their health provider are very supportive. So they might never really lapse into substance use. That's just one example of many.
Great, thank you.
So just in terms, Buck, of your question around data, Dr. Brian Rush, who's a researcher formerly at ARF and then at CAMH, has done a bit of a deeper dive into this. I've just pulled up one of his older presentations. I can share that if I can share my screen. And he has the. Would you like to see those numbers or?
Please.
Yeah. So he's broken it down, and are you seeing that screen?
Yes.
Yeah. So when you break it down, it does vary by subpopulation. So here's the overlap in the general population. So mental disorders, here's the concurrent disorders. So both substance use and mental illness at 15 to 20% in the general population. So when you look at substance use services, so, a provider view is going to be a little skewed because we see a greater proportion of people with concurrent disorders. So here you have 70 to 80% of people seeking service have a concurrent disorder. And then when you look at the mental health system in Ontario, 15 to 20%, young males, inpatient mental health settings, 55% mental health. And so those are some of the percentages he broke down. But and then in correctional system, 80 to 90% have a concurrent disorder. So that's so you need to kind of peel that onion. It's not there are. And as you get into those subpopulations, I think there are probably some more refined and evidence-based practices that we could draw on to have more effective impact on addressing these.
Okay, Buck. Great.
Chair O'Leary, I do see Dr. Zayed's hand.
Dr. Zayed, go ahead.
Good morning, everyone. I just want to comment on the local data use. So we encourage partners really to use local data, because without the data and the local context, we don't know our goals and how and why we are doing things. So there are data on mortality, local mortality due to drug addiction. And there are data also related to opioid overdose, alcohol overdose, and both. And I find that there was some, with the coding of these data, there are some errors in collecting the data. So we are also in public health working on correcting these errors, but nevertheless, these data are available, and it gives some impression on how by months and by year, where do we go? So without this data, I don't think we will be able to do effective planning. And from a public health perspective also, evidence-based intervention is a culmination of local context, data, research, and what are the resources that we have. So this is really a lot of this all together.
Great, thank you for that.
Mr. Chair, if I may just add a small comment to what I started with.
Sure, go ahead.
Thank you. So during the pandemic, there are many consequences of the pandemic that are direct and indirect, and mental health and substance use have definitely been some of. You look at the data coming from Saskatchewan, and it is national data, very refined data. When you look at suicide, there is no change in suicide rate whatsoever in 2020 and early 21, I believe. So again, I was dumbfounded when I look at it, because usually there is correlation between all these things, and suicide is one of these categories of mental health or mental illness. So it is important, it's empirical to look at the data and what's going on, and whenever we implement an intervention, the consequences of those interventions. Thank you.
Thanks for that.
One thing I would just add to that is sometimes we have to go with evidence-informed practices if we don't have the local data to support a full, to say this is what we've got going here. But I also would say, as Dr. Ara was speaking to, the one time we know that it's not one time that we're going to have an interaction with somebody. So I would just like to emphasize the continuum. It can be a roller coaster. It's not, okay, we're going to go to rehab, and after rehab, then everything's going to be, well and tickety-boo. We know that looking at the full spectrum of the social determinants of health, if they're not all in place, then people can relapse, people can fall, and we can set up a physical environment where they are going to fail again. Where if the strength of the social capital is not there, if the housing is not in place for them when they come out of treatment or come out of an institution, that it can fail. So once again, it's, that the road that Francesca started us off looking at, and that snakes and ladders is what I would take it to. You can get all the way up with the ladders and move up in the game and then hit a snake. And if you don't have that resilience or you don't have the resources, you can drop down again. And personally, feel like under the pandemic, we lost some really good people that were getting ahead graduates. And personally, it impacted me terribly that they had been making great strides. And then under very strong external environmental stressors and opportunities, they took the wrong path, and it led to overdoses and deaths. So once again, looking snakes and ladders is where I would go in terms of trying to figure out, as Dr. R speaks, the points at which we know intervention is good. It may be evidence-based or evidence-informed. This is how we do it. But keeping people on the ladders going up is a big challenge.
Okay, thank you, Jill. I think committee, we're going to take a 10-minute break here. If we can, maybe a little less. Why don't we come back at 10 after 11 and just make sure you shut off your videos, please. 11:10. See you in a minute or two.
Sandra, do you want to try to check your mic now?
Is it working now, Allison?
Yeah.
Oh, awesome. Great.
Yeah, there's a little like tinny or something, but totally can hear you. Yeah. Okay, now we know. I'll leave you alone now. Can have a break.
Just waiting for a couple of more, Mr. Chair, to rejoin.
Okay.
Okay, you do have quorum, Mr. Chair, so you can continue if you'd like.
Okay, before we move on to the next speaker, is there any other questions or comments for Jill? Seeing none, I will mention too, just to bring to your attention, there are a couple of comments in the chat, one from Alison Govier and another from Dr. Zayed. We'll move on here to item number 5, Community Safety and Wellbeing Plan Coordinator, Tanya Roberts. Tanya, you have the floor. Good morning.
All right, good morning, everybody. Let me just share my screen here. Actually, sorry, give me one more. There we go. All right, so I'm Tanya Roberts. I'm the Community Safety Wellbeing Planning Coordinator, as mentioned. I appreciate the opportunity to present to you today here. So just quick overview of the presentations. I'll be giving our organizational mandate, our governance model, the programs and services offered, and our gaps that we've identified. So I'm going to blow through a little bit of the overview just because there are quite a few slides and for the sake of time. So this all came out of the Ministry of the Solicitor General, and it's legislated under the Police Services Act. So it's mandated. The plan we have approved as of July 1st, 2021, and approved by both Bruce and Grey counties. So this is a joint council plan and multi-sector collaborative approach. So I'll show you a slide a little bit later of all of our partners. And again, it's been created regionally for 16 lower tier municipalities led by Bruce and Grey counties. So what is community safety wellbeing planning? So this is the framework that was provided by Ministry of Solicitor General, and it's focused on crime prevention through social development. So as you can see here, this bullseye, we call it, is shows you through the social development that I'll talk about shortly around incident response through risk intervention, prevention to social development. So the goal is to get from our incident responses and those emergency services and focus on social development. So those preventative strategies. So some of the key outcomes of community safety wellbeing planning include increased coordination and collaboration between services, improved access to services, greater alignment on key safety and wellbeing issues, a reduced demand on crisis and emergency-driven services, enhanced evidence-based decision-making, and systems planning. So what is social development? Social development is about improving the well-being of everyone in society so that they can reach their full potential. It means investing in people and removing some of those barriers that other stakeholders have already mentioned today so far. So in talking about, I think Dr. R mentioned earlier around social determinants of health. So just to put that in a framework around risk factors and protective factors, that's how we look at this in the community safety wellbeing framework. Around, we have all these risk factors that are, again, evidence-based, and then we have protective factors that offset those risk factors. So here are some examples of those, and there are also, there's different levels. So just to give you a quick overview, risk factors are negative influences in the lives of individuals or a community that may increase the presence of crime, victimization, or fear of crime in a community, and may also increase the likelihood that individuals engage in crime or become victims. Whereas protective factors are those positive influences that can improve the lives of individuals or the safety of a community, and these may decrease the likelihood that individuals engage in crime or become victims. So the goal is building on existing protective factors that makes individuals and communities stronger and better able to counteract risk factors. And then also just to mention that there are 4 levels identified which is individual risk levels, family and peer risk levels, community, school, workplace risk levels, and then societal. So identifying those accountability frameworks in each of those 4 levels is really important, and having each of those emphasizing through protective factors. So crime prevention and social disorder. So there was a report released in 2014, and it was, I believe it was put together by all of the police chiefs. So it was a task force similar to this mental health task force. And they identified in this report that 75 to 85% of police calls now involve something other than chargeable offenses. So those relate to public safety and mental health. Whereas those traditional calls, they've diminished in crime, have diminished over time. So the data from the report identifies that crime rates across Canada are showing a downward trend, while police calls for service to address social disorder are on the rise. And social disorder refers to potentially harmful and victimizing activities and incidences that are not chargeable under the Criminal Code of Canada, the provincial statute, or municipal bylaws. And according to this report, social disorder calls dominate the efforts of emergency responders, and preventing social disorder could have a significant effect on reducing the victimization and the costs of emergency response. And so social disorder signals the presence of conditions that lead to antisocial behaviors, many of which again are not chargeable, and left unchecked, they can evolve into those self-destructive and criminal activity. So the causes of crime and antisocial behavior that have been identified in the report are economic and social inclusion or exclusion, substandard housing, negative parenting, addictions, ignorance and illiteracy, and inequitable distribution of social power. Communities that invest heavily in social development by establishing protective factors through improvement in things like health, employment, and graduation rates will experience the social benefits of addressing the root cause of crime and social disorder. So this is our, we call this the regional system leadership. This is our model, our governance model for the community safety wellbeing. So the point is, again, that we use evidence-based decision-making. So we have some data from our indicator report, which I believe it's been released publicly, and I did speak to that in a previous presentation. So hopefully everybody's had a chance to take a look at that. We've been going through a gaps analysis with our action tables around this data. And then also we have data coming out of our STAR, our situation table for acute risk. And so we'll be using this data to inform leadership and decision-making at our advisory committee level, and then to also prioritize actions through our action table planning. And then we have our steering committee, which is the intersection between our advisory committee and then the coordinator. So my role oversees my role and the deliverables. And then we have our municipal rep working group. So that is bounded by a municipal agreement. And the plan is legislated to be actioned at a local level. So working in this group to identify an assessment tool that we identify those opportunities for social development. And then we have our champions in the community. So there's over 72 partners at the advisory committee level that came together to create this plan. And the roles and responsibilities, again, at the regional level is to facilitate the process for regional initiatives or strategies supported by the local municipalities as per the municipal agreement. And additionally, the role of the Bruce municipalities and Gray municipalities is to support any initiatives, programs, tasks, or projects at the local level as identified in action plans. So our current action tables are 5 priority risk areas identified in the plan or in the planning process. And we have 3 identified action tables already. Our community drug and alcohol strategies, Allison. We have our Bruce Gray poverty task force, Sajil. And then we have our homelessness response table identified as action tables that already existed in the communities. We are working on a mental health action table. So I'll be setting up stakeholder discussion. So we're in the process of putting that together. And so just wanted to make a note just to avoid that overlap as we'll be working across Gray and Bruce counties. So I think the information and data coming out of this task force will be really useful in how we kind of strategize and set that up as well. So I appreciate the opportunity to be involved in this. And then our crime prevention table. So we have a terms of reference, and we're putting together a recruitment and plan for that and doing some background research. So again, that indicator framework has been released. If anybody wants a copy of that report, feel free to reach out and I'll send that. And we've been identifying a gaps analysis just to see which actions are local, are better implemented at the local level, whereas others require more advocacy at different levels of government. And again, I've mentioned that municipal working group. So one of our services, I guess, that we offer through this community safety wellbeing is that we brought the situation table. So we relaunched the situation table that had existed in Grey Bruce for, I believe, 5 years prior. And we launched this through the community safety wellbeing governance structure. And so that is currently being facilitated and coordinated by myself and with police services. And the situation table meets on a weekly basis. So we meet every Tuesday. And essentially it offers wraparound services within 24 to 48 hours, ideally. Some of the situations are quite complex, but we have at least 20 member agencies or organizations that sit at this table that come together again to identify their lead and assisting agencies for those wraparound services for people identified as an acutely elevated risk in our communities. So here's an example of some of those communities or those organizations. So we have from our police, we have government organizations, we have nonprofit charities, we have health and mental health, child and family services, victim violence prevention services, and Indigenous serving. And at the situation table, there's no age range or anybody from any background or age is welcome to be brought to the situation table for those wraparound services. So it is, and again, going back to what was mentioned earlier around those coordinated services, this is one tool where we can come together as organizations and do that coordinated service of wraparound supports. And it does the STAR. Again, back to the Ministry of Solicitor General, there's a risk tracking database where we then use the data coming out of our situation table through our referrals and our report back forms. And then we populate this tracking database and then can identify trends over time and create reports for, again, that better evidence-based decision making. So just to give you an example, between 2016 2020, there were 17 situations filtered through the STAR process over a 5-year period. And since meeting in July 6 on a weekly basis, from July to December, we had 9 situations filtered through that process. And then we've had another 6 in 2022. So what is acutely elevated risk? It's a reference to any situation impinging on individuals, families, groups, or places where circumstances indicate an extremely high probability of the occurrence of victimization from crime or social disorder. So left unattended, such situations will require targeted enforcement and or emergency responses. So think of it as that in-between place where it's about to become, many of our calls or our referrals were involving, preventions of evictions, known evictions, and trying to prevent that, trying to prevent the police and emergency interventions. And so the acute nature of these situations is an indicator that either chronic conditions have accumulated to the point where a crisis is imminent or new circumstances have contributed to severely increased risks of victimization. And a situation may pertain to a single individual suffering the onslaught of multiple risk factors. So this is where they're complex, multiple risk factors where no single or even pair of agencies can offer those wraparound services. So it goes beyond that case management approach. It may pertain to something that's happening to a whole family or even a group of people. It could involve a neighborhood environment, a family and a person. And it may even pertain to a single, as mentioned, a street address or a property where there's that risk to public health or safety. And so the word situation gives us many entry points for dealing with threatening risk factors. So here's just a little bit of data. And again, there is a report that's available and I'm working on the reports from January of 2022. So this shows that there were slightly more females than male. In the age range, we've got a majority of adults from 30 to 59, and still significant of adult. And there are cusps on the cusp of adult, but as you'll see in these next situations, but this did show a good chunk of those adults as well. So in terms of risk factors, of the 9 situations filtered through the STAR process, 100% of the cases involved escalations of mental health related issues. 8 of those 9 cases were referred by police services who had been receiving increasing calls regarding the individuals under discussion. And again, going back to that kind of 80-20 principle where most of those calls they're getting are now for social disorder. So it's not something that they can use their typical tools, to apprehend or to deal with. So of these 8 situations, 5 involved individuals who were living alone and experiencing reoccurring mental health episodes. 6 situations involved the use of drugs and or alcohol. And 2 of the situations included eviction notifications and were presented in hopes of preventing these evictions. And 5 of these situations included threats to public health and safety. So of the new situations since January, there have been 6 situations brought to the situation table involving 3 males or 5 males within the age ranges of 18 to 29 and 1 female, age 40 to 49. So those referring organizations in this, with these 6 situations were the Ministry of Community and Children Social Services, the Youth Probation, we had Grey Bruce Health Services, South Bruce OPP, Bruce Grey Child and Family Services. Organizations taking the lead responses were Grey Bruce Health Services. Many of the same referring agencies were identified as the best leads for that, as you can see, and also CMHA. So those risk factors of these 6 situations, 4 had a diagnosed or suspected cognitive impairment and were unable to meet their basic needs and or unwilling to have their needs met and did not have access to appropriate housing. All 6 included criminal involvement and had a diagnosed and or suspected mental health issue. 5 involved drugs and displayed antisocial behavior, and 3 included suicide risks. So for the STAR outcomes, intersectoral collaboration, again, we identify in some of these situations, we have a framework for assessing them. And, if there's agency gaps at the table that we realize that there were, in a few of these situations, it was asked that we bring in kind of community living, regional support associates, other agencies that were better able to talk about the person and the risk factors, and then identify solutions. Increase vulnerable people's use of services. So again, identifying those gaps of accessing services, those system level gaps, proactively connecting people to those services. In a lot of these instances, with CMHA, with Grey Bruce Health Services, YMCA, on multiple occasions, we've had, people discharged into homelessness or facing evictions, and YMCA have done an amazing job at least being able to temporarily find housing solutions for these people. A reduced demand on policing and emergency services through intervention planning and risk mitigation. And half of the situations referred to STAR in 2021 had overall risks lowered through mobilization of services. So community engagement. So we did do a second survey. There was a survey launched in 2022 to consult with and better understand the public on their feelings of well-being and safety in their communities around the core, those 5 core risk priority areas. So the second survey follow-up was launched in April 2021 to May to identify how the COVID pandemic impacted those perceptions of safety and well-being. So the core 5 risk priority areas remain the same. The only adjustment was that mental health was rated number 1, whereas the previous year it was addictions and substance misuse that ranked number 1. So a little bit of, we had the open-ended questions, and so I've included here some of those open-ended responses. So around mental health, people mentioned issues of loopholes, and there were over 400 comments. So this is just a summary of those main comments. So issue of loopholes and vulnerable people slipping through the cracks, more supports for addiction, mental health, and affordable housing, a need for a big picture strategy in dealing with mental health and unsafe situations, especially regarding appropriate housing. Closure of mental health institutions placed a huge burden on our communities, especially for those suffering from severe mental health illnesses with little to no family supports, long wait lists for critical mental health and housing services, no emergency responses for mental health crisis and stress due to COVID fatigue. And I'll just add to that, in some of our situations, I think 3 of them, we did end up the agencies ended up referring these people to more appropriate housing that didn't exist within Grey Bruce, but the wait lists were very long. So addictions and substance use, So substance use has become normalized, drug abuse, the need for more supports for addiction, mental health and affordable housing, more public education on substance use and the connection to mental health and wellness, increase in illegal drug use and drug trafficking, availability of drugs and risk to youth, increase in drug use among kids and youth, cannabis shops in connection to addictions, the issue of marijuana smoking on beaches, appropriate and equitable healthcare for those with addictions experiencing overdose-related medical crisis, impaired driving, and drug subcultures in small towns. So these were concerns overall from the people that conducted the survey or responded to the survey. So identified gaps. So, through these 15 situations and our community responses, we have identified some gaps. So of the 15 situations presented, again, since July 6, 2021, 4 of these situations remain AAR, despite having services mobilized. 5 of these situations remain open still, which is actually now 4, and 3 have been put on a wait list for more appropriate housing outside of the Grey Bruce area. So this indicates that a potential gap may exist in Grey Bruce regarding a support model for people with complex overlapping risk factors. So where we see mental health, addictions, cognitive, developmental challenges, and then that antisocial criminal behavior. So again, that risk to self or public or to others. So many of these situations involve chronic offenders who are before the courts when they are brought to STAR, are unable to meet their basic needs and are unwilling to have their basic needs met, are homeless or at risk of becoming homeless, and have burned bridges across the region when it comes to supportive housing options. So many of these people have been told that they're not able to come back to many of these supportive housing and social housing across Grey Bruce. And I just wanted to leave you with this picture around identifying what those root causes of crime, because I did hear a lot of great suggestions around that social development, those social determinants of health. And then there was that, Francesca had shared that picture with you as well. And then, so this deals more with kind of, where I mentioned those 4 levels of risks. So the accountability of kind of those risk and protective factors and where they lie. And then all of the different layers in community that overlap to help kind of come up with these strategies. So the partnership, that collaborative governance framework, multiple multiple issues being addressed. And then that change coming out of that. So answering the following questions: what crimes are being committed, who is committing the crimes, when and where are those crimes being committed, and then it shows here to look for root causes. We need to get a better understanding of why the crimes are being committed, and to do this, begin by examining the risk and protective factors, again, at those 4 levels. So really kind of coming at this with a risk assessment and risk management framework. Again, the community safety well-being being a crime prevention strategy, but acknowledging that extensive kind of system leadership and collaborative perspective, because these challenges are very complex. And I have heard many staff saying that they're kind of coming to the end of their skill sets. So everybody's being stretched. And that's everything in my presentation for today. So if anyone has any questions.
Okay.
Go back to that.
If you could stop sharing your screen so I could see everybody, then I could.
Absolutely.
There.
Oh, there we go.
Boy, I'll tell you, I'm kind of laughing at myself. I know I'm not the sharpest knife in the drawer, but I just feel exhausted trying to take in all this information. There's so much work being done. Wow. Great.
It's a lot. It's a lot to talk. I feel, yes, I should cut my slides back.
Crazy. Okay. Any questions, comments for Tanya?
I see Councillor Keaveney.
Councillor Keaveney, go ahead.
Thank you very much, Mr. Chair, and I certainly agree. It is a lot. I made a lot of notes and I'm really listening and trying to take in as much as I can. But a comment and a question, if I may. First of all, I wish I'd kept track of how many times housing was mentioned today. I think that is the number one takeaway for me again and again from every presenter is the need to deal with the lack of housing. But my question, if I may, for you, Tanya, you mentioned an unwillingness to have needs met, and I'm wondering if there's any strategy underway to reach folks and encourage folks who are not yet interested in receiving supports or treatments. How is the group feeling about trying to go forward with, as I say, reaching and encouraging folks to accept supports?
Yeah, that's a tricky one, especially with the situation table, because there's a lot of regulations around consent and privacy. So there, people do have that right to refuse services. And so in some of our situations we have, it's been a challenge because some individuals just don't trust government, they don't trust police, they don't trust others. And so it is difficult to get those supports to them. There's intervention strategies, whether those are door knocks or a team kind of following up and adding kind of new members to that intervention planning team. But again, that issue of consent is a really important piece. And I know we probably could have a lot more situations referred, if we didn't have that strong issue of consent. And ideally, we get consents for people as they're being referred to the table, but in that acutely elevated risk, when it gets to the point where the person is at risk to themselves and others, we are able to kind of intervene on their behalf. But that is another kind of topic of discussion around kind of forming clients as well, and understanding how, what are the tools. What are all the tools in the toolbox around dealing when you have somebody that's not able to care for themselves, not able to take care of themselves, aren't willing to accept care. If you're in that situation, what kind of tools do you have that break out of a lot of the barriers, I guess. That would be a barrier, I would say. Meant to protect people, but
Mr. Chair, you have Dr. Zayed, then you have Naomi and Jill.
Okay, Dr. Zayed, go ahead.
Thank you, Mr. Chairman. Thank you, Tanya, for this great presentation. I really enjoyed it. I just have a few questions for you regarding the database source. Did you use any database rather than cases that you have, or through the survey? And if public health is involved or partner in this collaboration, there is also a question about unregulated congregate settings. Do you have data about that, or only you have data about CMHA supervised congregate setting?
Sorry, Dr. Zayed, can you clarify what you mean by that congregate setting? And how, I'm just trying to see
So
how
congregate settings are like group homes. So long-term care is a congregate setting, but there are unregulated congregate setting where we find more of mental health addiction issues. And these are unregulated. It's just like a group home. Yeah. Some of them are for profit with low income population housing.
Like those rooming homes or things like with landlords. Gotcha. Yeah. So the risk tracking database, it only tracks what I have coming into the referral forms, and then the report backs, which is basically risk factors. So risk flags. So whether, mental health addictions, we have somebody that's at risk of suicide or at risk of harming others, or has criminal background, or, vulnerable. What are those social vulnerabilities? So it's very, regimented and very structured in how we present the situations, collect that data, and then are able to generate those reports. So it would be based on study flags, not necessarily details around any particular types of housing, or I can look into, the database is quite extensive, and but it's de-identified. So you really want to make sure that the information you're adding you're not able to track specific locations or people. It's generalized de-identified data. And you're just trying to understand those risk trends. So age ranges, here are the risks, here are the results.
But you are not collaborating with public health in terms of population data?
So yes, so for the indicator report, I believe, so public health is one of our partners. They're on the steering committee. And I believe that there was local data provided in the indicator report. But for our situation table, we just are using the data coming out of that risk tracking database. So no relationship with public health. It's just what's coming through that situation table. But from a larger perspective in our indicators, our local level data indicators, that I believe did come from multiple sources, including some local, some public health sources.
Yeah, just the last comment. The CCHS data is public health data and is very valuable data because you deal with proactive guidance and proactive planning rather than only responsive. So the CCH 2021 data will come at the end of April. There is also the rapid risk factor surveillance data that we requested and we resumed this year. And the first cycle, which is related to COVID and the impact COVID is especially mental health, will come to public health end of April.
End of April, thank you.
Thank you.
Thank you for that information.
Okay, next up is Naomi.
Just in response to the question about what we can do with some of these more complex patients. I know we've already talked about housing, but again, I think the variety, the type of housing, not one type of housing can fit everybody. Sometimes we need a supervised congregate. Sometimes we need an apartment building with multiple people, like supportive type of individual apartments. And sometimes we just need really one apartment here, one there. There's just such a wide variety. And it just reminded me of a patient we had quite a few years ago who had been in and out of jail, in and out of the inpatient unit, very, very complex, had been to all of our tables. And it wasn't until we did get him the right kind of housing, which for him was one little tiny apartment on his own. And he did so well, and we have not seen him in hospital. He's a valued member of our community. And so I think for even these most complex clients, there is a solution. We just need to be willing to, really explore a lot of options.
Okay, before I go to Scott, sorry, Heather, there's one more. Was it Jill?
Yes, it was, sir.
Okay, Jill, you
Yes,
go ahead.
thank you. I was just going to speak to what Naomi spoke to, is matching people to the right type of housing in order to keep them from revolving in the system, I think is still really critical. The other thing too, in terms of data collection, I was just reading through Safe and Sound's annual report, which has been submitted to various funders, including Grey County. And I think that's a piece of data that needs to be added. What I found striking, and I don't have it to share and I apologize, but what I found striking in some of the data was that people were not necessarily reported as receiving mental health peer counseling in the large numbers. But what you saw was some of the other things that had attracted them to Safe and Sound. So I think what we need to look at is what attracts somebody to a space that builds the trust, that starts the stepping stones towards giving that permission to go forward and access other services for mental health and addiction services. So quite often there are many steps that a person will take before they trust the system. And the Safe and Sound data that they've just released for the last year speaks to that, where there was the largest number of, people were there for the social, but we knew how many times you could go for the social interaction and the peer support until they would actually be in a position to make a decision. So just a recommendation to everybody to look at what's been submitted to Grey County. I'm not sure, Anne-Marie, if that report would have gone to you recently with that data, but look at that in terms of what is attracting people to a service prior to them then possibly accessing other mental health and addiction services.
Okay, thanks, Jill. Councillor Mackey, go ahead.
Thanks, Mr. Chair. And I'm not sure if this question is for Tanya or for Clark. Just wondering about the embedded mental health worker with the different police agencies. Wondering how that program is going and whether or not you expect any expansion of that program.
So we are just heading into an evaluation of that program, but we've been embedded for probably about a year or more now. And it is, we're still challenged with resources because we can't cover 24/7. So our workers are in there for a portion of the time, and it is luck of the draw whether or not the calls come in during that time. We always have someone stationed on what we call the regional desk as well. So if there's always someone, a worker on, say, at night, but the call may come in from, Hanover and the worker is in on sound. So it takes a while for the person to get there. But it is showing, we have some anecdotal evidence, but we are heading into more robust evaluation of it. So we can report back on that.
Thanks, Clark. And if I could just follow up, do all the police services have the ability to reach out to the mental health, the embedded mental health worker? My understanding was Gray OPP maybe didn't have access to it, and we're looking at funding opportunities. Can you confirm that, please?
Yeah. So in terms of the history of it, the Owen Sound Police Services were the first to approach us, and we were certainly eager to try it out. We didn't have any extra resources, so what we did was just do it within internal resources. So we reconfigured our resources internally to stretch them and place some in there. The other police services were interested in it, so we did the same, and we stretched as far as we could. During that process, the Gray OPP were going through some leadership changes, and they weren't consistently at the table. So we were, when we sort of stretched as far as we could with what we had. So that's why they were not sort of included in that. But yes, they have sought other funding, and they will hopefully be successful in that. But we do have all police services covered off, and with the exception of Gray OPP. Yeah.
Thank you.
Okay, any other questions?
You've got CAO Wingrove, and you've got Allison Gofier, Mr. Chair.
Hey, Kim, go ahead, please.
Thank you, Mr. Chair. Just to go back to a point that you made on an earlier slide, Tanya, about increasing coordination and collaboration in order to meet needs being one of the primary outcomes of the community safety wellbeing plan. And I look at that and I think about the conversation that we had earlier in this meeting about the need for system navigation. And I kind of feel like this is kind of the crux of the matter, and part of the reason why we're here at this task force is to really understand where those intersections are and what should be done to improve things. But I'm on the outside looking in. I feel like in some ways the community safety and well-being folks are on the outside looking in. And so I turn it back to Clark and to Naomi and the people who are actually delivering the service. Is there a path forward here or do we need to be, is it about cooperation and collaboration, or is it about resources, or a combination of those things? I'm just trying to understand, if I can, how best to move forward and to support you, given that your funding models are so different. I just like to hear some comments if you can, or we can pick this up at another meeting since it's getting late if you'd like more time.
I'll jump in. I think it is a bit of a combination of the two. And I sort of recoil a bit when I keep on hearing system navigation. We've been talking about that for a long time, and really there's something wrong if we need someone to navigate us through the system. We need to restructure the system so that it's simple to follow. If it's that complex, then something's wrong. I think a presentation that may be helpful for the task force is a presentation from the OHT planning committee as well, because that is a huge piece of work that's going on in the healthcare system, which is being restructured, which is the biggest restructuring since Medicare was adopted. So that I think is an important piece of context. So collaboration is essential. As providers, we need to stop talking about our clients and start seeing ourselves as their providers. Any person is going to have multiple providers, and we need to see ourselves in that light. As a system, we need to learn the language, and we need to learn how to come together structurally. There are things that work against us. There's competition for resources, and that in past, certainly in the mental health and addiction area, has worked to our detriment. So, the development of the OHT, the Ontario Health Team, the local table, have great hopes in that is a mechanism where those conversations should be taking place when new resources are introduced. Where's the best place to put them in the system to realize the best result and we need to kind of define that result. Is it improving health status? Is it improving mental health or physical health? Those are not going to be easy conversations. There are all kinds of dynamics within any system, as you're aware. I'm sure within municipal politics, there's all kinds of dynamics, and so too within the healthcare system. So from my perspective, we are over the past 20 to 30 years, we have been on an iterative process, which has been evolving a more collaborative environment, which I think have seen between District Health Council days to LIN days to now OHT days. So I think it is developing slowly, but some of those structural pieces were, and they're tied to the political as well. We're into the election season, and so we're seeing that, and it's very hard to uncouple healthcare from the politics of it as well, which is one of the challenges. Which part of these, this is my, I guess, own personal interpretation, but certainly the LINs were to squelch out some of the politics by putting that funding at arm's length from the minister, and so too with the OHTs, which will eventually, if they achieve it, put it at the OHT level. So yeah, collaboration is absolutely imperative, and ensuring, because even sector by sector, we have blind spots. The view from the acute care is very different from the view from the community, view from primary care, view from long-term care, and they all intersect at some point.
Thank you.
Kim, I wonder if we shouldn't make that like a separate discussion for another meeting, because I just think it's huge. I remember making a comment way back at I can't even tell you the meeting now. And I remember saying, all I hear about is collaboration. Everybody's working together, and from where I sit, I don't know what everybody does. You hear about this organization is overworked and underfunded, and you just don't, like, I'm starting to learn there's so much going on, but it seems to me there's no one at the top directing what everyone else is doing. And it's I don't know if it's right to say that. I don't know if it's, maybe public health should be overseeing all these different organizations so that there's better collaboration. I don't know what the answer is, but I think we should have a separate discussion on that. But
yeah, and just as a point of clarification, we are at a point of transition with the restructuring. So we no longer have the local health integration networks. We now have Ontario Health, which is a huge behemoth of the whole healthcare budget. And it has 6 regional offices. So they are just finding their feet as well. So in terms of that direction where we had the LINs that were fairly, finding their groove, that structural piece is just finding its footing. In mental health and addiction, we have the Center of Excellence for Mental Health and Addiction, which is part of Ontario Health, which focuses in, and that might be an interesting presentation to have to see what's going on at the provincial level too. But that top to provide the direction is they're just finding their feet right now.
Okay, thank you, Allison.
Oh, thank you. I put my hand down. I'm okay. I don't have anything to add. Thank you.
Any other questions or comments? Before we move
Mr.
on.
Chair, it's me, Dr. Era. I totally agree with your point. I do believe what we need in Grey Bruce is a collective plan. We do have a lot of collaboration, healthy collaboration. Arguably, I do believe we have sufficient funding. I can speak for the health unit. I believe we need a plan, collective plan. Thank you.
Well, I appreciate those comments. Thank you. Okay, we're going to move on here to correspondence. I'm going to ask Kim to speak on this correspondence, but I need a mover and a seconder to receive the correspondence. Councillor Mackey and Councillor Hutchison. Okay, Kim, go ahead.
Thanks, Mr. Chair. And I'm going to turn this to Naomi because this is a GBHS announcement and I wouldn't want to steal any of the wonderful spotlight on the work that you've put so much time and effort into bringing to fruition. So Naomi, would you like to say a few words to the task force?
Sure, we're very excited. So we have quite a large plan for in total 45 new addiction beds, and that ranges from medical, I'd say more of a soft medical detox to treatment to supportive housing. We have been calling it the Bayview Project. We have not finalized the lease or the purchase of Bayview and have a couple of other options that our executive team is working on. So we're really hoping that it is the large space that we had envisioned. Our plan, Francisca's off the line now, but the way she talked about a recipe is how we really looked at it. We looked at having all the ingredients in this building, and every person who comes in, whether it's for medical detox, supportive housing, wherever they enter into the building, we'll have a case manager assigned to them, and then we'll help get them to OW, to ODSP, to treatment, to whatever they need. So that is an essential part of being in this space, is that you have someone assigned to you to help you navigate. And we have peer support workers that we have budgeted into the program. And we really hope to have further communications with our partners, all of you on the line, and make sure that this space does in fact have all the ingredients that we need to make it work. So
Naomi, it wasn't appropriate for me to ask during, like, when they made the announcement, because it just wasn't with everybody there. But I just wanted to ask you about the amount of money and what you were looking for. Is it satisfactory? Is that what you were looking for? Were you looking for more? And maybe talk about is this going to turn into solid long-term funding? Or do you know?
Well, yes. So yeah, we have to produce results. So we do need to really look at, there's some software out there that actually, and we that can do some measurement-based care that we're looking at. And we also have our tool, our patient, it's like a satisfaction tool, the OPOC tool. So we need to produce results in order for it to have long-term funding. But yes, we are expecting long-term funding. We are very committed to the project. And sorry, you asked about, just had a brain, you had two parts to your question. One is, do we expect long-term, and
did you get enough?
No, we didn't. Having said that, we got lots, but yeah, we had significant cuts. For one thing, we have, if it is in the Bayview School, we do have a 4-bed mini unit there. I think I've spoken to a lot of people in this group before. And what I said earlier is there's such a variety of needs of what people need for housing. And so we know that some people really need a much more intensive small space. So we built this 4-bed mini unit that had 24-hour staffing. At this point, we have no staffing to that 4-bed mini unit, but I'm really committed to working with our partners to figure out how do we do that. But again, I need the commitment of the space before I make that plan. There is some gaps. There's gaps around the kitchen. We had the kitchen, the greenhouse. We had some more recreational thoughts that we really want, and so we are pulling some of our staff from our other programs to work into that space, because what we've done is we've looked at their caseloads in terms of how many do they serve now currently with a mental health and addiction concern. And so then we're really kind of doing a bit of a reorganization of our staff to support the Bayview project, but we will be reaching out to everybody to ask that same ask. Is there a way that you can, it's probably work you're doing anyways, but if we could put it in there, and I'll just say like some of the social rec, certainly that CMHA does, some of the social enterprise, Safe and Sound, OW, all these services can be, if they're there, they're probably the same patients you're already seeing. So we're not thinking it's more, just different, kind of like SOS has been doing, trying to do things a little bit differently.
Okay, Heather, I don't see any other hands.
No, sir.
Okay, I'll call the question. All in favor? And that is carried. Thank you. Okay, number 7, other business. We have a resolution. First need a mover and a seconder. Moved by Councillor Mackey and seconded by Councillor Carlton. Not sure if I was going to ask, is Dr. Ara still on?
Yes, Mr. Chair.
Dr. Ara, could you just speak to this maybe? I know that back when we first brought this up, you that talked about, the age group, we have to start at 0, which kind of surprised me a little bit, but I wondered if you wanted to comment on this resolution.
Certainly. Thank you, Mr. Chair. I do believe our partners around the table have invested in very strong programs in harm reduction and preventing complications. The mandate for public health and the core work that we do and the most return of investment we do is in prevention, way before people actually end up in a situation that we need to support them. And there is overmounting evidence that early childhood development and early childhood in general, up to age 18, any intervention that we do early on in increasing resilience, providing mental well-being education and strategies to cope with stress is very useful and would have excellent return of investment. So to that end, we need to support, we continue to support people who actually are suffering at this point. And the presentations that we heard today and previously speak to the excellent programs that we have, and we need to continue this work. But at the same time, we also need to focus on prevention and education in the school system, providing children with the tools that would allow them to navigate life with better well-being is key. So that's my perspective, Mr. Chair. Happy to elaborate more, or if you would allow Dr. Zayed to add a bit more, if I can ask through you.
I think Dr. Zayed skipped out to take another call, so she's not on anymore. Councillor Mackey, go ahead.
Thanks, Mr. Chair. I was wondering, not to put Mr. Dodd on the spot, but he is our resident expert around children's mental health. I'm just wondering what his thoughts are on this resolution.
I think it's a great resolution. I would maybe suggest a document that just came out last week or the week before from the Knowledge Institute on children's mental health and addictions. And I did send the link to that page to Tara just prior to the meeting. And it certainly supports the linkages between the school systems and specifically individual boards of education and the community-based mental health services and the full continuum of services. And it's a 80, 90 page document. It's a pretty boring read for non-social workers, but I would suggest that if you looked at page 27 of that document, it provides a really nice diagram of the work of the school board and their mental health services, of which they've had increased supports over the last several years, or the last few years, they've had increased mental health supports. So it provides the work that they do in mental health and promotion. And then it also overlaps what the community-based children's mental health sector does with the higher end, the higher needs level 1 and 2 people in the system. So that's just in that document. And if you're okay with Tara sending that out, that would be great. And there are a lot of other great articles on that website in that link under resource hubs. If you go into that link and there are a lot of other great articles in there that would support your resolution moving forward. But this one in particular, it cites actual research that they've done in having that early intervention piece within the school boards in a local level, and it really speaks to what you're trying to, I think what you're trying to say in this resolution. So I would perhaps cite it if you want to pass that on to the Ministry of Education and Minister Tabolo from the Ministry of Health and Mental Health and Addictions Division. I think it would have some weight with supporting the resolution.
Okay, thank you, Phil. You're good, Scott? So I just wanted to comment, like, I'm pretty excited about this. Not often we have the opportunity to try and make a difference without throwing a bunch of money at something. And if we can ever get this through, and Kim and Heather, I appreciate the way you've done this. We're able to get this away so that we can, with the election coming up, but hopefully if we get it in the queue, regardless of how the election turns out, surely common sense will prevail and we'll get this through. Before I call the question, I don't know, Kim, did you want to comment at all on the resolution?
No, Mr. Chair, I agree with you. I think it's worthy of moving it forward. So these minutes will appear hopefully in the council package for April 28th, and we'll be able to move them forward from there.
Right.
Mr. Chair, I do see Allison's hand.
Okay, Allison, go ahead.
I just have a comment about the timing of, or a question, I guess, about the timing of this recommendation. I understand it's being put forward now because of the election that's coming up. I think I could argue that any of the recommendations that are put forward as a result of this group would be relevant to the provincial election. And I wonder what prompts this one to move forward at this time. And I also wonder, what is the role of the school boards, the Blue Water District School Board and the Catholic School Board in this task force? And do we have a sense of what is already being offered at the primary school level with respect to resilience and mental health?
Mr. Chair, I'll take this if you want.
Sure, go ahead.
Allison, this was raised at an earlier meeting. I'm not sure if you were there, but I'm happy to discuss it with you offline if you'd like, just to kind of catch you up on the conversation that happened earlier. And certainly I anticipate that through this process, there'll be a number of various initiatives that get moved forward, as well as the recommendations that will be in the final report. So I think we're just trying to respond to things as we have them and get them, move them along as merits. And I know that there was some good conversation outside of this table that indicated that there were people who were willing to assist in moving this forward. So we want to take advantage of that. And the final point is that the school boards are scheduled to attend and present to the task force at an upcoming meeting. So we'll have an opportunity at the same time to get more information from them.
Thank you, Kim. Yeah, and yeah, I was present for the initial meeting when this was discussed, and my comment at that time was that perhaps public health could also assist us in understanding the social determinants of health in a comprehensive way to address the prevention piece, that looking at the individual, looking at the education to the individual, in this case, it would be the student, is one piece of the complement of approaches that would be needed for prevention. There's also the family piece, the community piece, the institutional piece, the policy piece, that would all kind of need to come together in a comprehensive approach to address prevention fulsomely. So I guess I just wanted to raise that as perhaps something to look forward to in future meetings, specifically because we do have public health as part of this working group. And the reason this comes to mind for me is because as part of the opioid working group back in 2020, public health promoters put together a framework for opioid use prevention. And they drew on Peel region public health framework, which really looked at those preventative and risk factors and how to integrate those into like multiple settings, not just within the schools. So I just wanted to bring that to people's attention, that that framework has been started at public health, and I would love to see us take that up again, whether it's at the opioid working group, the drug strategy, this group, wherever it needs to be. Thank you.
Great, thanks, Allison.
Mr. Chair, I do see Clark's hand up, but I'm just going to caution the committee. We are having people leave because of other commitments. So I don't want to leave the resolution on the table. So if we could vote on the resolution, and then if Mr. McFarland has some additional comments, we can certainly hear from that after the motion is decided.
Okay, yeah, we can do that. Thanks, Heather. All right, I'll call the question. All in favor? Thank you. Anyone against? That is carried. Thank you so much. Clark?
You know, I just wanted to jump in to say, just to note the work that Jackie Ralph is doing with us in the schools already. And we can certainly provide you with some of the impacts that's having. She is quite a force, and you know, goes into everything from the grade schools right up to the high schools. And then in other areas that we touch, youth would be our talk today, where we liaise with the OHL and team, as well as we have a pilot going with the local swim team in Owen Sound as well. But Jackie's program is unfunded, so we do that all through fundraised dollars as well. But I think the school is a good place. It does have an impact. The kids do go back and talk to their parents, and you know, I think it creates. It's just one piece, as Allison said. I think that's an important point as well. It is just one piece. And creating a bit more awareness of the services that Keystone offers, that we offer, and that the other resources are out there too. So.
Okay, thanks, Clark. Just moving along here, I just want to thank Francesca, Jill, and Tanya for their presentations today. Great discussions, rather long meeting, but that was good. We had some good discussions. Our next meeting is on the 17th of May at 1 o'clock. And I need a mover and a seconder for adjournment. Councillor Burley is the mover and Councillor Hutchinson is the seconder. All in favor? That is carried. Thanks,